Hello to everybody and welcome to this IMS webinar. I'm Professor Rossella Nabbi from Italy. I'm the President-elect of the International Menopause Society, and I welcome you all to this nice webinar. And we have two fantastic speakers from the United States, the two coasts of the United States. They will address pay attention on your way in. The vulva is an important organ too. And it's my pleasure to introduce them because I know them personally and they are a very good friend of mine. The first speaker is Dr. Jan Shifren, and she's a professor of obstetric and gynecology and reproductive biology at Harvard Medical School, and she's also the director of the Massachusetts General Hospital Midlife Women's Health Care Center in Boston. And then we will have Dr. Tami Rowen from beautiful San Francisco. She's an associate professor of OBGYN at UCSF and director of the sexual medicine program and even perioperative service. And she is doing a fantastic job as an associate editor for the Journal of Sexual Medicine. So I think we can move forward, and just to thank Besides Healthcare, this webinar is supported, as many others, by an unrestricted educational grant, and it's very important. I assure you that Besant Healthcare has no role in the selection of topics, selection of speakers, and have not vetted or reviewed the content of the speaker's presentation. And therefore, we are ready to go to discover more about the vulva. Please, Jan, take the floor.
Well, it's an absolute pleasure to be part of this webinar. Great thanks to Rosella and the IMS, really, for the opportunity to speak with you all today. And of course, to pair me with Dr. Rowen, who is just an extraordinary speaker. And I think together we will really cover a really complex and important topic for our midlife patients. So I'll be speaking about the management of the genitourinary syndrome of menopause. I have no disclosures. I always like to begin with a case very typical of women that I think we all see in our practices. So this is a 58-year-old teacher who presents with vaginal dryness and pain with sexual activity. She experienced menopause at age 50, had some hot flashes, which resolved by age 53, but the vaginal symptoms worsened with time. Lubricants were helpful initially, but now they're no longer adequate to treat her symptoms. She reports a really satisfying sex life prior to menopause, but the couple is now engaging only in non-penetrative activities, and they both miss intercourse in the relationship. So we will cover in the 20 minutes we have this morning, hopefully, how prevalent is the genitourinary syndrome of menopause, or GSM. And of course, it does encompass vulvovaginal atrophy. How is it diagnosed? I'll cover that right now. History and exam, and what treatments are available, and are they effective and safe? And then following my presentation, Dr. Rowen, very important kind of that the presentations are together, will cover so many other causes of similar symptoms. And again, without a thorough history and exam, it's really difficult to distinguish between the two. So I'm so glad we're speaking together and that you'll get both perspectives on why women at midlife may be having these similar symptoms. So how do we define GSM? Again, it does encompass VVA. So clearly there are symptoms. These are genital symptoms of dryness, burning, and irritation, sexual symptoms, lack of lubrication, discomfort, pain, impaired function. And very important to realize that, of course, the urethra also has estrogen receptors, and there will be urinary symptoms as well, often including urinary frequency, dysuria, recurrent UTIs. What are the signs on exam? There's reduced elasticity, pallor, and erythema, both pale and red, loss of rugae, and tissue fragility. And very important, women may present with some or all signs or symptoms. Again, all do not have to be present for the diagnosis, but most important, they must be bothersome. So, if you see on exam something that looks atrophic or dry, but the woman is having absolutely no symptoms, then she does not have the syndrome. And of course, most importantly, these symptoms and signs must not be accounted for by another diagnosis. And that's why you'll have a spectacular presentation following mine, so that we're all aware of the other diagnoses that can cause similar signs and symptoms. We think that GSM is highly prevalent. There are wide range of statistics for the prevalence. And I think at the end of the day, that's mostly because it's very hard to study because we don't have good endpoint measures. So this is just a little bit of plug to say that we are working really hard with NAMS and at the Midlife Center at Mass General to validate a patient-reported outcome measure, which will really help us all both study and identify women with this condition. So it's more to come on that. Maybe we can talk about it more during the Q&A. But from the best studies that we currently have, we think at least 50% of menopausal women have GSM. Unfortunately and sadly, only about 6 to 7% are adequately treated. Why is there such a low identification and treatment? We think there are multiple causes. One is that many women are really unaware that the symptoms progress without treatment. I mean, often I've heard women say, but isn't menopause over? Hot flashes have resolved, but they don't realize these symptoms will get worse and worse with time. And also both clinicians and women, I should say people, are not aware that effective treatments are available. And I should say I will be using she, woman often, and that is because most of our literature in this field does use women who identify as female and classic. But of course, most of what we talk about today will be, I think both for Tami's talk as well, will be relevant for our patients with other sexual identifications who aren't always cisgender and in heterosexual relationships. So very prevalent and undertreated. What are some of the sexual side effects? These are the REVIVE studies. They were done here by Dr. Kingsburg, an incredible investigator, and of course, done all over Europe by our very own Dr. Nappi. Really important studies which showed that GSM interferes with enjoyment of sex, sexual spontaneity, the ability to be intimate, and the relationship with partner. So big effect on relationships and sexuality. And then when studies also looked at male partners, and again, these were male partners, but I think data would be just as relevant for partners of any gender or gender identification, painful sex, loss of libido, and avoidance of intimacy for both members of the couple. So it does not only affect the person with the symptoms, but of course affects the relationship. Not to say that these symptoms aren't also important for women who are not in relationships, but can affect, self-stimulation behaviors and other non-partnered activities. So what are the treatments? There are some, but very limited data that activity may be helpful. And again, these are very limited data. A lot of it is more clinical experience. So activity may make a difference. We certainly know that pelvic physical therapy can make a very big difference. Don't forget that. And again, Tami will be talking a little bit more about things like provoked pelvic floor hypertonus, which is often secondary to GSM. And so really effective treatments beyond just medications. Non-hormonally, we often start with lubricants and moisturizers available over the counter. Topical lidocaine, we'll talk a little bit more about laser. And then, of course, I think we all do feel that our most effective treatment options, especially when other interventions have been ineffective, low-dose vaginal estrogen therapy, vaginal DHEA, the oral sermespemifene, and systemic estrogen therapy. And we'll talk more about those. Again, in general, systemic estrogen therapy would be for women who have concurrent vasomotor symptoms and other estrogen deficiency symptoms for which systemic hormone therapy is indicated. If the only symptoms are genitourinary, really the low dose of vaginal hormones would be your preferred option due to increased safety. So just a little bit, a reminder, pelvic floor PT really is very effective. I suspect that Tami will be discussing this as well. And so, please don't forget, especially often we'll start with low-dose vaginal estrogens. Then we look on exam, everything looks better, but the woman is still having, severe pain with any type of penetrative activity. Often on exam, you'll kind of feel that whole pelvic floor tightening up upon exam. And for those women, vaginal dilator therapy, pelvic PT, incredibly effective. As we mentioned before, often we really do start with the relatively, inexpensive, safe, over-the-counter, available without a prescription lubricants and moisturizers. Lubricants are specifically designed to reduce friction with penetrative sexual activity. So those are typically used by often both members of a partner or could be put on a device or toy at the time of sexual activity. Vaginal moisturizers, on the other hand, are really designed to help the vagina retain moisture. They should be used on a regular basis, typically every, several times a week, and again, very safe. Some wonderful data, thanks to our current president of the IMS, Nick Panay, that it's really important we inform women to choose lubricants and moisturizers that are safe. They should be what we kind of call, you know, really like almost a biosimilar, is similar to this vaginal secretions that women make prior to menopause as possible. And so that's in terms of things like osmolality and pH. I always tell women, please avoid ones that are identified as being, zesty, zippy, good flavors, fun scents. They should be unscented. They should be uncolored. They should just be, hypoallergenic. The postmenopausal genital urinary tissues are delicate and they should be treated with care. Lots of options available in general for lubricants. They're water-based, silicone-based, kind of petroleum-based, and they can all be effective. I typically encourage women, couples, people to try different brands and see which ones they find the most effective and pleasurable for them. Water-based are best, let's say, for our premenopausal patients, especially if they're considering fertility, trying to get pregnant. They are rarely irritating, but do dry out quickly. I think the silicone ones tend to work very well. They last a little bit longer. The nice thing about oils and petroleum-based products is they're very inexpensive. I've had a lovely couple who said, we just use oils, olive oil when we want to think about Italy, and when we'd like to go to the Bahamas, it's coconut oil. They can be messy, they can stain under clothes or bed sheets, but again, they're pretty inexpensive and a nice option. So again, I think it's good for women, couples, people to try different products. What about vaginal laser? There is a lot of interest in laser, particularly for women who either don't respond to low-dose vaginal hormones or who prefer not to take them. The data is kind of based on the effectiveness of laser for skin conditions of the face. And we recently have had warnings from the FDA here in the United States. I suspect there are similar warnings in other countries, really, that we should not be using these, quote, to rejuvenate the vagina for vaginal cosmetic procedures. There are not well-designed studies that have really proven efficacy, most importantly when there's a placebo laser, and there are potential risks, heat-based injuries, especially when they might not be used by experienced providers. So it is important that women are aware none of these are really approved as devices for these indications, and there are potential risks. A very nice study out of Australia, and again, I know there are people probably in this audience who are still using vaginal laser. It's not that there may not be certain women who may respond, but it is important to realize that currently the best study we have did not show efficacy greater than placebo laser. So it is really important. We've actually done some of these studies in the United States that the laser be, placed in the vagina, turn on, make the buzz, make lots of noise. We know that placebos work. And so we do have to be certain, especially with a very costly and potentially risky treatment, that the benefits outweigh risks. And as you can see in this study, there were certainly benefits in the best validated questionnaires available at the time, and they were similar between laser and sham. So what about low-dose vaginal estrogen? It clearly has a lot of important biological effects on the vagina, thickening the epithelium. You can see that basically a histological slide of the vagina will look very premenopausal after several months of use of low-dose vaginal estrogen therapy. Many products available. It would be fun to talk during the Q&A what products are available all over the world. That's one very exciting thing about being in an IMS webinar. We really can learn from each other about what's available all over the world. But in the United States, and I know in a lot of Europe and Canada, we do have creams, of course. They're typically placed 2 to 3 times per week. They are very effective, but they can be messy. Some women like them because they can kind of put a little bit directly on the vulva. There are inserts. These are very convenient. They're placed, and both the insert and the tablet are typically placed daily for 2 weeks and then twice weekly. Again, sometimes women find them hard to remember to use. They do have to be used on a regular basis to be effective, but they're very effective and easy to use. And then a terrific product is this very low-dose vaginal ring placed in the vagina changed 4 times a year. It works for 3 months. At least in this country, the principal drawback is it's very costly and often not covered by insurance. But one nice thing about it, of course, is that you don't have to remember really to use it. You just have to remember to change it 4 times a year. Very low dose of estradiol released all the time. All of these products are estradiol. So for your patients who really want bioidentical or natural estradiol for their vaginal estrogen therapy, it is FDA approved or government approved, but estradiol. There is an estradiol cream, again, for women who prefer bioidentical, but there are also conjugated estrogens and other creams available. This is just a little bit of a summary of what we just talked about some of the benefits and drawbacks to different products. One other thing about the ring, some of your patients who've had a hysterectomy may be able to keep the ring in the vagina. For some women, they may not. One other thing I should mention when you're thinking about which formulation to choose for your patients, in general, we'll talk about this a little bit more later, but there are almost no medical contraindications to low-dose vaginal estrogen therapy. I'll show you some data. They are minimally absorbed, essentially do not raise blood levels. And so even women with heart disease, leg and lung clots, and breast cancer really may be candidates. If I have a patient for whom systemic hormone therapy would be contraindicated, let's say a patient with breast cancer or recent heart attack or pulmonary embolus, I do typically prefer that she use one of the dose-fixed products, the tablet, the insert, or the ring. And that's simply because with the cream, we don't have the same data on resulting blood levels because there's so much variability in how much women may use or absorb. If you used a lot of the cream, clearly you could get a bump in systemic blood levels. A very nice Cochrane review that essentially all of them are equally effective. And so I do again, encourage women to try different products and then see which one they find most effective and comfortable and convenient for them. These are the data to show you blood levels. If there is a ring available, an every 3-month ring, trade name FemRing, which actually provides systemic estrogen therapy and is FDA approved to treat hot flashes. So very important if you are using a ring in your patients that you make sure in this country, the trade name is Estring for the ring that provides microdose estradiol, solely approved for vaginal dryness. And then the other ring in this country is called FemRing, which provides systemic estrogen therapy vaginally. So again, it's a terrific treatment for hot flashes. In this country, at least, it is very expensive, so rarely used. But I do like to show you that if you use systemic doses of estradiol in the vagina with a high dose ring, you will get systemic blood levels adequate to both preserve bone density and treat vasomotor symptoms. But when you use these dose-fixed microdose estradiol products, here's the tablet, the insert, which comes in both 4 and 10 micrograms, very low dose, or that microdose estradiol ring, what you can see is basically there is no bump in serum estradiol levels compared to untreated postmenopausal women. So I think this is very reassuring. If I have a patient with, heart disease or stroke or leg and lung clots, it's often very reassuring both to the patient and her internist that we are not raising systemic blood levels. The one group of women for whom I'm most cautious with any formulation of low-dose vaginal estrogens are our patients with breast cancer using aromatase inhibitors to reduce the risk of recurrence. Because in those women, the goal of course, the aromatase inhibitor is to basically take the very low levels of estradiol circulating in menopausal women and make them almost unmeasurable. So even that relatively low level of estrogen that we see with our low-dose vaginal estradiol products, may be a little bit more of concern. Again, I always speak with a woman's oncologist when she has breast cancer before prescribing low-dose vaginal estrogens. I know here in Boston, our providers are really generally encouraging if these symptoms are interfering with quality of life, and other treatments have been tried, non-hormonal lubricants, moisturizers, pelvic PT. So again, an option, but for your patients on an aromatase inhibitor, that's the group to be most careful. In this country, and again, it will be really fun to discuss in the Q&A what you have in the package insert for your low-dose vaginal estrogen therapy products. But unfortunately, you're in the United States. exactly the same package insert that women would have if they were using systemic estrogen therapy to treat hot flashes. And clearly this is very stressful and concerning for patients, such that I do prepare them in advance that they will see this in their product. Because if you don't prepare them, they'll open it, be very concerned, their partners are concerned, they've just spent the money on the copay and they won't use the product. I typically tell women to be really informed about their drugs and medications, but this is one time when I'll often say it may be best just not to read the package insert. We, with NAMS, I don't know what's happened internationally, it'd be really interesting to discuss, have worked with our FDA to try to modify the label. And they say, well, it's estrogen, and we have not made a lot of progress, unfortunately. This is a very reassuring study that we've done with the Nurses' Health Study. There's one also with the Observational Women's Health Initiative study, both of which show that in an observational study, real world use, women using low-dose vaginal estrogen therapy, we do not see an increase in any of these concerns, including things like stroke, MI, DVTs, cancers. So very reassuring real world observational use. I do remind all postmenopausal women, whether they're using low-dose vaginal estrogen therapy or not, any postmenopausal bleeding, including spotting, requires an evaluation. Typically, we'll start with a vaginal ultrasound. If the endometrium is thick, we'll do a further evaluation, often including an endometrial biopsy and maybe a sono-HSG or hysteroscopy to rule out a polyp. So any postmenopausal bleeding, whether or not a woman's on low-dose vaginal estrogens or systemic estrogen therapy, requires evaluation. We need to remind our postmenopausal patients of that. But otherwise, we do not use progestogen therapy with low-dose vaginal estrogen therapy generally. I also like to point out this lovely study from one of my colleagues at the Mass General, Dr. Caroline Mitchell. Again, when comparing estrogen therapy with lubricants and moisturizers, they look, equally effective. A lot of, clearly this study was only 3 months. I think long-term, we have a lot of women who start finding efficacy with lubricants and moisturizers, and then of course, ultimately do need low-dose vaginal estrogen therapy for benefit. Carol and I discussed this a lot. Clearly the placebo was not exactly a placebo. It was this hydroethyl cellulose gel, which likely was quite effective. We've often told Dr. Mitchell she should think about marketing that. So, but it is a very reassuring study that it's appropriate to often start with the lubricants and moisturizers, especially in our patients with a contraindication to estrogen therapy. But for most women, low-dose vaginal estrogen therapy will really be effective and safe. We do have another hormone therapy. It's a vaginal DHEA, again, a very low dose of DHEA in the vagina. It has been shown in double-blind randomized trials to be both effective and safe. It is government approved. Often this is preferred by some of our patients on an aromatase inhibitor because it is an androgen and they're taking an aromatase inhibitor. You probably will not see that slight bump in estrogen levels that you might see with low-dose vaginal estrogen therapy. Very important to realize that in women not on an aromatase inhibitor, the serum estradiol levels with this again are not increased above baseline. So another really good option for patients with GSM. And then there is an oral SERM called aspemifene. It will be fun to talk in the Q&A whether this is being used much in Europe. There wasn't much take up here in the United States. I think most women didn't want to take a systemic medication every single day for a local problem. But again, definitely effective, safe, and approved. This would really be a terrific product for our patients at high risk for breast cancer because there are data that it decreases breast density like other SERMs, but it's never been studied in women with breast cancer, and so really not indicated for those patients, even though it might be a great option. So kind of in summary, GSM clearly adversely impacts the health and quality of life for many midlife women. I should also mention that GSM does not affect just sexual activity. We found in studies, as have many others, it can affect the clothing choices women use. It can affect their ability to exercise comfortably. So it can have an effect on daily life, not just sexual function. It is often unrecognized and untreated. There are effective and safe interventions, including lubricants, moisturizers, low-dose vaginal estrogen therapy, vaginal DHEA, aspemifene, pelvic PT, and really, because our low-dose hormonal products do not bump blood levels above those seen in untreated women, we really do anticipate a high degree of safety. Thank you so much.
Thank you, Jan. I think all the people listening, they will keep the question for the end, put in the system all the question, and I give the floor to Tami Rowen for sexual pain disorders. Please, Tami.
Thanks, Rosella and IMS for inviting me to speak. It is an honor to be speaking for the International Menopause Society. I'm going to be talking today about really sexual pain disorders. So really dyspareunia as it relates to the vulva, and more specifically the vestibule. And we'll talk a little bit more about what I mean by anatomy as I go on. Let me see if I can get the... Okay. These are my disclosures. And then just along with Dr. Shifren, I'm going to be using the word woman, but as I live in San Francisco or work in San Francisco, there are many people who don't identify as women who have the similar anatomy and will suffer the same kind of problems related to sexual pain and their vulvas. My goal for this presentation for you is really to be familiar with the important questions that can determine the cause of sexual pain and how we examine that, really in a thorough physical exam, and think about at least 4 different conditions that could be related to sexual pain, especially in the vulva, and then different treatments, right? So it's not just that, how do we take a history? How do we examine? We're here to help our patients, and there actually are treatments available. And one of the things I think that is important about following such a great lecture on GSM is that in our older patients, there is oftentimes an assumption that all of their sexual problems or their vulvar vestibular problems are going to be related to GSM. And I want us to expand on what the differential can be, because I think that that assumption makes us miss certain conditions and their treatments. So I'm going to start with 3 different cases, all of patients I've seen in my clinic. The first one is a 47-year-old who presents with an inability to achieve intercourse. She's never actually been able to insert anything into her vagina and always thought that she was just small. She tried to have sex at age 18 and it caused such severe and sharp pain that she never attempted again. She has no history of trauma, no other medical problems, and is otherwise happy in her life. So you wonder, why am I seeing her at 47? It just did not become an issue in her life. But now she is coming to you. She had seen another gynecologist that told her this must all be in her head and that she should just try to relax. Another case is going to be a 51-year-old woman who presents with 3 years of a chronic fissure. Any pain, any touch to the area elicits pain. And she's having bleeding now with any penetration. She's in a monogamous relationship, stopped menstruating about 2 years ago, and has no other medical conditions. She has been seen by multiple providers. They've repeatedly treated her for a yeast infection, tested her for STIs, assumed she just had GSM, and then told her there was nothing more they could do for her condition. And then finally, here's a 59-year-old who presents with worsening pain with intercourse. She's always enjoyed sex. She feels like she's having a sharp pulling sensation now. She's been in menopause for many years, started hormone therapy for perimenopausal symptoms at age 45, and then underwent a hysterectomy in the setting of complex atypical hyperplasia. She has hypertension and she regularly exercises. She thinks there's something that went wrong with her surgery, and again was told this is all in her head and that she should just try to relax. So what do these patients all have in common? Well, they're all having pain with sex, and that was really the focus of this talk. And in my introduction, one of my focus really is in sexual health, and that can relate to all aspects of sexual health. But one of the most important things I think that we miss when we talk about in gynecology in general is the importance of the vulvar vestibule to sexual health, as well as the vagina, right? And so pain is dyspareunia, and it's really important to get a timeline because the history oftentimes can give us the diagnosis. Has sex always been painful? Was tampon use painful, just placing something inside? Did it start gradually or acutely? Is it only during intercourse, or is there pain without provocation? Since the pain began, has one ever been able to have completely pain-free sex? And then are there any precipitating factors? And I want to know where the pain is. I mean, that's really the most important. So you have to get kind of detailed in your questioning. Is it upon penetration? Is it deep inside the vagina? Is there pain with deep thrusting? Are there positions that are more or less painful? Is there pain with clitoral stimulation? Is there postcoital pain? And what does that pain feel like? I teach a lot of medical students, and people get very shy talking about sex. You have to be very comfortable talking about what activities people are doing. And most patients are perfectly comfortable as long as they see that their provider is also comfortable. So let's look a little bit closer. So when we're talking about the vulva, and this is, again, I train a lot of residents and medical students, people don't really understand the difference between the vulva and the vulvar vestibule. So the vulva really includes all of these structures that you can see outlined on the left here, from the mons all the way down to really the perineum. And so that's going to include the clitoris and the labia majora and the labia minora. But most people don't have pain in those areas. So it's a little bit kind of general to say vulvar pain or vulvodynia. It's really pain in the vulvar vestibule. And the vulvar vestibule starts at Hart's line, which is where you see this change from kind of stratified squamous tissue over to more mucosal tissue. You can see the boundary outlined here on the left. That's really the boundary of the vestibule, and it goes up above the urethra, just underneath the clitoris, and then it ends at the hymen. And the hymen is really the opening to the vagina. And so I'm always kind of trying to explain that the vagina is deeper inside, the vestibule is on the outside. But patients themselves experience vestibular pain as inside pain. So I always have to kind of be, I'm like, is it on the inside or the outside? And they'll say it's on the inside. I once had a patient who said it was her cervix that was hurting when it was very clearly her vulvar vestibule. So just understanding that anatomy. And when you're doing your exam, the most important thing that you will see those of us who do a lot of these exams use is a cotton swab. So I use a cotton swab and I will touch the inner thigh and I say, this is what I'm going to be touching you with. It should feel soft. It might feel scratchy, but it is not supposed to hurt you. And so they know that when they feel it on their thigh, that this is not a hot stinging object. However, when you actually touch onto the vestibule, it oftentimes will elicit severe pain and burning. And that is vestibulodynia. All right. And you can get closer starting at Hart's line and then move more medially, especially towards the vestibular glands, the Skene's glands, which are just lateral to the urethra, and then the Bartholin's glands. Those are really going to be the most hormone sensitive areas, and oftentimes the most sensitive in general areas of the vestibule. I'll oftentimes ask people to give me a scoring system from 1 to 10, how painful is this? And so I can really document where it is that I'm touching and what their level of pain is. The next step in my exam of sexual pain is to examine the pelvic floor. And the muscles that I'm feeling for, so if you're looking anterior to posterior, you've got in this picture from the bottom, you've got urethra, vagina, and rectum. And really the internal muscles that you're going to be feeling for are the levator ani, which are the pubococcygeus and iliococcygeus, as well as the obturator interna. So those are the main ones that I'm feeling on the levator ani. And those and then from the outside, if you can touch the bulbospongiosis, just if you're touching kind of laterally along the labia majora, and then the transverse perineus are going to be the ones coming from the perineum over to the ischium. You can touch those superficially as well. And those oftentimes for people who have vulvar and vestibular pain may have sensitivity on those muscles. So what is pelvic floor muscle dysfunction? So you'll hear us say this a lot. It's not just tenderness, but that's really how you diagnose it because that's what you're feeling for. But it actually is implicated in the pathophysiology and presentation of vulvar and vestibulodynia. People can have that burning, sharp sensation related to hypertonicity of the muscles. And those muscles can be hypertonic for many reasons. Sometimes people have a history of overactive bladder. They can also have constipation and other things that can cause pelvic floor dysfunction. But then the pelvic floor dysfunction may also cause those symptoms. Now, there is an entity called vaginismus, which sometimes gets confused with pelvic floor muscle dysfunction. And pelvic floor muscle dysfunction is distinct from vaginismus. Vaginismus is really an involuntary contraction of the muscles. So people will describe it as it feels like a wall is being hit. They cannot go further the minute they try to put something inside. And that really is more vaginismus as opposed to pelvic floor dysfunction, where there's a sharp shooting pain oftentimes from insertion or from anything going inside or any kind of deep thrusting. So I do try to distinguish those two. In the US, we use the Diagnostic and Statistical Manual for diagnosing these sexual pain disorders, and they don't use vaginismus anymore, but it is a clinical entity. I do see it, but it is distinct from pelvic floor muscle dysfunction. All right, let's get back to the vestibule. So there's actually some classifications of vulvar pain that I think are important. And these were put together by the International Society of Vulvovaginal Diseases, as well as the International Society for the Study of Women's Sexual Health, which is kind of my main organization. So there's vulvar pain caused by specific disorders. These can also be infectious, inflammatory, neoplastic, neurologic, trauma, iatrogenic, hormonal, that includes GSM. And then if we really don't see a cause related to that, we'll actually just describe it as primary or secondary provoked or unprovoked vestibulodynia, and kind of, it's a little bit unclassified. But all of these conditions can cause vulvar and vestibular pain. And I think the assumption, especially for our midlife and older patients, that everything is GSM really can lead us to miss some of these. So let's go back to our cases, and I'm just going to talk us through some of these in some of the common presentations that I see. So this is our 47-year-old who's never been able to achieve intercourse. Remember, she can't place anything inside. She tried when she never could place a tampon. She tried to have intercourse and then just stopped. She was told it must be in her head and she should try to relax. In this case, after a thorough exam, you notice that her vestibule actually looks pretty normal, but on touching it, you're going to get significant tenderness and a burning sensation. Now, if you biopsy the tissue in her vestibule, you're going to find hyperinnervation. And we call this primary provoked vestibulodynia. So we will see this both in patients who have never been able to place anything inside, but there also is a condition called secondary provoked vestibulodynia, and we call this a neuroproliferative, where the nerves themselves are hypertrophied. And this can actually be triggered by many things. I see it oftentimes with yeast infections or bacterial infections. And this has been shown in lab studies that sometimes these infectious causes will provoke this hyperinnervation. People end up getting treated over and over again for a yeast infection or BV to try to treat this tenderness when it's really just hyperinnervation. Treatments are really limited, but there are some that you can try. So there's data on tricyclics and anticonvulsants, such as gabapentin. The best randomized controlled trial did not show a benefit from oral gabapentin, but I always like to say that this is group data and not individual data. So there are individuals who may in fact get better from using these systemic medications that target nerve pain, and there will be some that don't. There's been 3 systematic reviews that didn't really show a benefit. Again, you're going to see that you've got rates of success, from 25 to 100%. For some people, this works. One of the best RCTs that looked at tricyclic antidepressants plus or minus lidocaine didn't show that adding in the tricyclic antidepressant made a difference. So again, if we go just based on randomized data, you may say, oh, these things don't work, but I would argue that it's reasonable to try some of these in your patients, especially those that can't take a topical treatment. Trying something oral or systemic can work. There are topical treatments. So lidocaine is really the most obvious one, right? So it does help treat the pain as needed. There's really never been a randomized controlled trial in the absence, with the exception of a good trial that was done showing that women with breast cancer benefited from lidocaine. I like it PRN, so as needed for sexual activity, but I don't think it cures it. Other treatments that may in fact cure it, capsaicin, which can be very strong. And I would usually compound this and not get a commercial brand because it'll be an alcohol if you get it commercially, and that hurts a lot. Capsaicin daily for 4 to 6 weeks can be beneficial. Gabapentin topically 2 to 6%. Some people have used Botox to inject in the superficial pelvic floor muscles. People use nifedipine, nitroglycerin, interferon, even ketamine. I sometimes will use topical amitriptyline as well. And for some of these patients, I actually do find that giving them a compound of estradiol and testosterone may help, even if it's not a hormonal cause. I think that the way that I conceive of this is that the tissue is so sensitive to estrogen and testosterone that there may be some sort of repair mechanism that happens by increasing blood flow, and it helps heal the tissue. So that will be something that I will use. Now, you'll see us talk about this in sexual medicine. I'm not going to spend too much time on it, but there is a surgery that we will do sometimes where we actually will remove the vestibule. I don't usually do this in older patients. I usually will do this in younger patients. This is a posterior vestibulectomy. And then really this is a full vestibulectomy. This is kind of the best resource. I'm not going to spend too much time on it, but there is surgery for this condition. All right. Case number 2, this one here. So this is a 51-year-old woman with 3 years of a chronic fissure on her vulva. She reports pain to any touch. She's in a monogamous relationship. She's seen by multiple providers. She's been told she has a yeast infection. They've treated her for STIs. She also was told she had GSM. Nothing has made this better. On exam, she has this pale tissue at the fourchette with fissuring, and this can oftentimes be misdiagnosed. I'll see it as people think it's HSV. As I said, they think it's a yeast infection. They think it's GSM. But what is this? It's lichen sclerosis. And this is common and commonly missed. And what lichen sclerosis is an autoimmune condition. It leads to destruction of the tissue, loss of vulvar architecture, and scarring. We don't know what causes it, but it is autoimmune. There is a bimodal prevalence, so you'll see up to 20% in premenopausal women, but most of the time we're seeing this in our older patients. And that's why it's really important not to miss this. It is chronic, lifelong, and it can be associated with squamous cell carcinoma. That's less than 5% of the time if it's untreated. So that's why it's important to treat this and follow these women closely. These are some examples of what can happen. And the reason I show this is the only thing that really changes architecture like this, where you see this complete resorption of the labia minora, is really going to be lichen. But some patients with GSM, as it progresses, you'll start to see a little bit of vulvar architectural changes. And this is where it can get confusing. And I've seen patients who are told they have lichen sclerosis when they really just have GSM. But most of the time, it's patients with lichen that are told that they have GSM. So there's this kind of misinterpretation of what you're actually seeing. But here it's very obvious, right? The labia minora are completely resorbed. You can't really see a separation now at the entrance. There's scarring. You'll see that active lichen, especially at the posterior fourchette, and that's oftentimes what will fissure and bleed. This is where the clitoris is gone. There's no, you can't see anything anymore. That's lichen sclerosis. And that's where you're going to start seeing it progress into cancer potentially. So how to make a diagnosis? I really do recommend always getting a biopsy. I don't like telling people that they have a precancerous diagnosis without knowing for certain that's what it is. There are things that can look like lichen sclerosis that are not. If you're going to do a biopsy, always use an anesthetic. If you're going to use lidocaine, I usually will start with a topical lidocaine, and then I do the smallest needle possible, a 30 or 27 gauge. I use baby Tischler forceps, the kind that you use on the cervix. I find that I can really control that I'm holding the skin and get a nice bite. Otherwise, you can do a biopsy, a punch biopsy, but you actually don't need to go as deep as the punch biopsy will take you in order to get the diagnosis. So you really just need a superficial piece of skin. To manage, you want to just be doing general vulvar care, minimizing irritation, moisturizers with emollients. If somebody has GSM, I will give them topical hormone therapy because it strengthens the tissue to allow it to better absorb the other treatments. So if in a postmenopausal woman that has lichen sclerosis, if they're not already on topical estrogen therapy, I usually will recommend that they start with it. And then the key really here is high potency steroid. You want to use an ointment. It's going to stay on the skin a lot better. The most important one really is clobetasol. Mometasone and triamcinolone maybe as maintenance, but start with clobetasol. There's no ideal regimen here. Do it how you like. I usually like to do it daily for 4 weeks, then every other day, then twice a week, and then I see them back at 3 months. Success depends on adherence here. If they're not successful, they're oftentimes not adhering. There are other treatments like calcineurin inhibitors. So that's your pimecrolimus and your tacrolimus. They can have some immunomodulatory effects. They're not your first go-to. And there's some case reports of retinoids. We already talked about laser therapy. People have been promoting carbon dioxide labor, the fractionated CO2 lasers for lichen sclerosis. It does not work. This is not, it doesn't make sense physiologically why it would work, but there was a good randomized controlled trial that showed that it doesn't work for lichen sclerosis. So I really do not recommend that people do this, and they really should be using the treatments with data behind it. There is some evidence for photodynamic therapy, as well as argon dye laser, but again, nothing in those ones, nothing randomized. Okay, beware of red herrings. This looks like lichen sclerosis. So you see this lace-like reticular appearance with fusion and loss of architecture. And this is actually lichen planus. They look very similar. And really I'm not going to get into detail here, but lichen planus, the main thing about lichen planus is that it goes into the vagina and it goes into the mouth. So lichen sclerosis stays on the vulva. Lichen planus goes into other mucous membranes. And that's really kind of the key difference here. And then there's a couple other, the appearance of those little white reticular striae. But the treatment's actually very similar. It's going to be high potency steroids for both. Okay, last case. So this is our 59-year-old who's having worsening pain with sex. She is postmenopausal. She had been on hormone therapy. She ended up developing endometrial hyperplasia and had a hysterectomy and a BSO. And the sensation she's feeling really is a pulling sensation, as well as some burning on entrance. On exam, she now has severe atrophy. She has no tenderness on her Q-tip. Her exam shows a well-healed cuff with no tenderness, and her pelvic floor is showing significant tenderness over her iliococcygeus, obturator internus, and piriformis. So her exam is consistent with pelvic floor muscle dysfunction and GSM. And I put this in here because even though she's been in menopause for a long time and was on hormone therapy, the removal of her ovaries at age 59 took away any remaining systemic hormones that she was making. And so now her GSM has progressed rapidly. And I just want to put that in there as kind of an adjunct to say that, you can absolutely develop GSM worse after you've had your ovaries out, even when you're further into postmenopause. But for her, she also has pelvic floor dysfunction, and that could oftentimes be missed if we just assumed her pain was GSM. For treatment options for pelvic floor muscle dysfunction, PT, physical therapy, is really the best. The PTs use internal and home exercises and biofeedback, but there can also be a role for injections. And I will oftentimes inject with either lidocaine or bupivacaine, as well as steroids, plus or minus steroids. There's some controversy about whether or not they could lead to muscle atrophy, but I think in the short term, 1 or 2 injections can really decrease inflammation and help with pain in the muscles. And there is good data for Botox. It's not approved here. It's very hard to get it accessible, but a lot of patients are using this with benefit. All right, so final thoughts. There is no single treatment that is ideal. We have to do a history and a thorough physical exam. And then in anything related to sexual health, we always talk about the biopsychosocial model. So anybody with sexual pain or problems is going to have something going on that can affect them socially and psychologically as well. So I encourage us all to think about that holistically. And with that, I'll end my presentation, and I'm looking forward to the Q&A.
Fantastic. I think we cover very well the diversity of what we can see in clinical practice. And with Jan, we really focus on the traditional view of vulvovaginal atrophy, and now part of genitourinary syndrome of menopause. And with Tami, we really address the issue of sexual pain as part of the GSM syndrome, but also as different diagnoses that we really need to recognize in our daily practice. So we're ready to go with the question, and I would like to start with Jan. And there is a question that has to do with progesterone. Why we do not prefer progesterone in women they are treated for estrogen receptor positive breast cancer, given the concept of intracrinology? What's your opinion, and why is not standard of practice in your view, Jan?
Great question. So what's interesting is if you actually look at the resulting estradiol levels, if you're using, let's say, one of the tablets, the vaginal estradiol tablets, or you're using vaginal DHEA, you actually have the same resulting very low, but resulting serum estradiol levels. So basically, they're both local hormone therapies, and they both probably result in the same, serum estradiol level. So I think in a woman who is not on an aromatase inhibitor, I really think you could use either. And it's okay to use low-dose vaginal estrogen therapy as well. I think the one group of women, and again, this isn't really supported by any specific clinical trial, the group of women with the ER-positive breast cancer taking an aromatase inhibitor, then there might really be a benefit because that DHEA, the androgenic components are not being converted to estrogen in those women. The drawbacks in this country, and again, it's always nice to have an international audience, the vaginal DHA here, there is no generic, and it's very costly. And so I think one main reason that a lot of us use low-dose vaginal estrogen therapy is the principal prescription is that we have some generic formulations and they're much less costly for our patients. But this is just more clinical practice, again, not FDA approved, but I know from my patients that often to make the vaginal DHEA more cost effective, it is a daily use prescription. And a lot of patients get, clinical benefit just using it, let's say 3 times a week. That will save a lot of money. So that's again off label, but I would say that's the only reason you might choose one over the other is just some of the practical considerations.
I absolutely agree. We have now an experience, as you mentioned, with ospemifene in these women, but not when they have the disease, the active disease treated, but afterwards. And we are doing quite well, but it's expensive as well. And also, as you know, it's not available in so many countries. I just want to say also that some colleagues, they are saying that this is an excellent webinar. And so this is, I'm very happy about that because I think speaker, they do the difference. And there is another question. I don't know if you want to address, both of you, how it can be useful in clinical practice to test vaginal pH as an indicator of something wrong going on in the vagina. And I'm wondering if maybe Tami can comment a little bit on the difference in vaginal pH and vulvar pH, if this can have a role. Let's think about intimate hygiene or other procedure to preserve or to promote vulvar care. So I want to ask to both of you, what do you think about that?
So I can get really nerdy about this. So most people know that the vaginal pH is low, right? Which means it's more acidic, and that's related actually to the acid made by the lactobacilli who eat the glycogen that's made by the estrogen. So like it's this beautiful kind of story of the importance of the estrogens and the androgens that contribute to this acidic environment. And so when you have lower androgens and estrogens related to GSM, you're going to see the acid level go down, which means the pH goes up. That said, I am not someone who really believes in treating tests. I treat patients. And so if somebody isn't complaining of symptoms, it wouldn't occur to me to necessarily test their pH. If they're complaining of symptoms that I maybe am having trouble seeing, so it doesn't look like GSM maybe, but typically I only really test pH when I'm trying to rule out some sort of infectious process. GSM, it's usually pretty obvious when someone has GSM by their appearance and their symptoms, but that's really my style. I think it can be helpful certainly for research purposes in looking at the efficacy of different treatments to see the change in vaginal pH, because again, that's directly related to the health of the vaginal microbiome and those lactobacilli that make lactic acid.
I mean, Tami, that was beautifully said. I completely agree and really nothing to add. I think vaginal pH has some role maybe in a research setting, but I think in clinical practice, really not very helpful.
There is another very interesting question for an Italian attendee. What about cream with the cannabinoid oil to treat the GSM? I was sure that this question came out, so I don't know who wanna answer. Jan.
I'm not sure if it's Italy. It's legal in most states here, including Massachusetts. On every corner, more or less, here you can purchase it legally. But I would just say I think we're in a data-free zone. How's that? And maybe Tami has any more experience. But it seems like people are putting the oil in everything, and I just wish we had more, placebo-controlled data, because of course placebos work really well. So, Tami, any thoughts on that?
Yeah, I mean, my thoughts are that, again, physiologically, it's hard for me to understand how it would help the, what's happening in GSM in terms of the anatomic changes related to the loss of hormones. That said, symptomatically, I think it can be very helpful for various reasons. We will never have data in the United States, not because people haven't tried. I've actually looked on like the randomized controlled trial to see is there anything going on. And it's not that people don't want to do it. It's that the FDA has set an impossible bar for testing anything related to cannabis. And so it's very unfortunate because it would be, people are using it. It would be really helpful to get data, but I don't think we're ever going to have it because the requirements of the safety data that they're requiring to even just start the study is insurmountable from a cost perspective. So maybe in Europe, you guys don't have the same kind of regulations and can start this.
I'm aware that some women, they have started using this product, because they are advertised, they are fancy, etc. But there is no clear data out there, and so we cannot endorse that, okay? We really need, as Jan said, placebo-controlled trial to really recommend something in our clinical practice. Women, they can try everything. You remember they put yogurt into the vagina just to deal with mushroom, and so a lot of stuff in there, down there. There is another very interesting question from a colleague in Mexico, and he is asking about the use of vaginal testosterone or DHEA orally to treat genitourinary syndrome. And so what about your thought, Jan or Tami, your experience with vaginal testosterone or oral DHEA?
Tami, tell me, in general, because in this country there is no FDA approved, kind of high quality testosterone products available for women, I really do tend to use low-dose vaginal estrogen therapy or vaginal DHEA because, they're both approved and effective. And so can't really see a good reason to use something else. When we use compounded products in this country, it's really buyer beware. We don't know what's in the product every time the woman purchases it. It's a different product. We have no data on absorption and safety. So I do tend to avoid compounded products. And that's really what we have here for both oral or topical androgens for women. Some women will use the FDA approved testosterone gels for men and try to dose adjust them. But my concern there is that these are really high potency for women, 10 times more than they would ever need. And there's just a risk of overdosing and potentially, androgenic risks and side effects. So I really don't use it much. I think we have some good kind of approved products, but really curious for Tami's thoughts on this.
So I think for GSM, I don't usually use it unless they're not responding to the topical estradiol, because we know there's androgen receptors all over the vulva, the vestibule, and the vagina. So that's where I'll sometimes bring it in. And the other time that I'll bring it in is when people are feeling decreased clitoral sensation and decreased clitoral volume, because testosterone will help increase that. So I'll oftentimes give them again, it's compounded. I'm very particular about the pharmacy that I use, but I agree that oftentimes we don't know the safety and quality from a lot of compounding pharmacies, but I'll oftentimes have them use a very small 0.1% testosterone just to the clitoris, because it does increase blood flow, bulk, and sensation.
Yeah, US is a big country, and you see more liberal California and more conservative Bostonian area. But it's true. I agree with both of you that, in my view, GSM or these kind of symptoms are not a life-threatening condition. So to me, safety always comes first. But of course, there is the individual woman out there, and we try to help her. And so sometimes, me too, I prescribe a lot of compounded testosterone cream, 2%. We use that, because it was an older treatment to treat, for example, lichen sclerosis, and we do quite fine. We have also some vegetable testosterone we are using now in Italy, but it's always very difficult, when you use this product, because you don't know how much patient use sometimes, and so this is important for safety in some cases. And on the same line, there is another question from a colleague that say, I use a lot of vaginal cream, I suppose estrogen cream, also in the outside. So I prescribe one day internally and one day externally. So I want to comment a little bit with both of you on the fact that if we do not prescribe according to the instruction we have in the box, we may obtain different results. For example, in terms of absorption, how is the value of putting local estrogen to the vulva, for example? It's for both of you. And if you comment a little bit more on the absorption of products, depending on the internal part of the vagina, external part, etc. Something dealing with the safety of the product depending on the area of administration. So Jan, please, or Tami.
Tami, do you want to start? Do you want me to start?
I'll let you can start.
Okay. As I mentioned when I was talking about products, I mean, one reason why a lot of women do prefer the creams is they'll often say, I have one area on the left that's always sore, and they like that ability to kind of locally treat where they're feeling their symptoms. And so I think that is a real benefit of the cream. And often I'll say to women, if you're going to use half a gram 3 times a week, you can put a little bit inside with the applicator, but then also feel free to put some on your finger, put some on the outside, wherever you think it may be beneficial. And so I think that is one of the real benefits of the creams. I don't really know of any data, and maybe Tami does, on like blood levels or differential absorption. My general sense, it's really safe to put it in both locations. And for a lot of women, that is more effective than just putting it in the vagina. And there are occasionally times when I have women who really prefer, let's say, the ring. It's incredibly convenient. They love it, but they're like, there's just one area in the vulva that's often sore. Probably not vulva, right, Tami? It's vestibule. And then I'll say, well, terrific. Here's a second prescription for some cream. Feel free to use it where you're having that discomfort. So not necessarily evidence-based, but again, our goal is to individualize for the patient. And again, these are very low doses of topical local hormone therapy, so very safe.
Yeah, the only thing I would add is I just want to make sure I understand when we're talking about inside versus outside, because I do think that some patients are placing the estrogen on their labia majora. That is part of the vulva, but as I said, that's not really where it goes. That's stratified squamous tissue, and it's not going to absorb. If you think about how low dose this the estrogen is, the mucosal tissue, especially higher up in the vagina, absorbs hormone incredibly well. And so you're going to see higher systemic absorption the higher up the estradiol goes. We used to say the vulva doesn't absorb hormone. That's not true. It does. And so we still need to be careful when we're putting hormones on the vestibule. I meant the vestibule, not the vulva, the vestibule specifically, but the rest of the vulva, the labia majora, minora, they're not really going to absorb it. So I'm always when patients tell me they're putting it there, I'm like, I don't think that's not really where it goes. And that tissue doesn't have estradiol receptors. The mucosal tissue in the vestibule and the vagina does.
Great point.
Fantastic. Tami, I think there is a question from a big guy in the field. I know him very, very well.
Oh, no.
He asked, do you advise patients in treatment to allow vulvovaginal penetration except if it's accompanied by pain? Do you take care to avoid painful penetration during the vulva evaluation? Do you consider the role of Bartholini secretion during sex response and the absence of it in postmenopausal women? Very difficult question from an expert in the field.
I think I don't understand the question.
I think the question is, how much do you consider painful penetration when you evaluate the patient? So you avoid the penetration if it's painful until you treat the woman. I think this is the key message of the question.
You mean in my exam, or how do I counsel them about sex?
Exactly. And if you consider Bartholini secretion, if women, they understand the secretion.
So, so a couple different questions there. So when I'm examining somebody, it's really important to form a trusting therapeutic relationship. And I tell them, I am not here to hurt you. What I do, when I'm examining you, this may elicit pain. If usually I start with the Q-tip test, and that, depending on the extent of how much the Q-tip hurts, sometimes I don't go any further, but most of the time I will, say I'm going to, gently place one finger right on the entrance. But if it causes too much pain to go in, I stop. And I'm like, you know what? We need to treat the entrance and get it less sensitive so that I can get to the point that I can examine internally, because I'm really not there to traumatize patients. I don't think they should be hurt during the exam. So if I get the vestibular pain and it makes me unable to go forward, then I won't do any more. When I'm treating somebody who is able to achieve intercourse, but it hurts, if my concern about them continuing to have sex when it hurts is that they get into this negative feedback loop. And it's really hard, like their muscles will contract during sex. It's really hard to treat pelvic floor dysfunction if then they're constantly assaulting the same process. And so I'll oftentimes tell people to really try to avoid penetrative sexual activity and do things that are more pleasurable while they're in the process of treatment. And this is especially true for people who I think are misdiagnosed with vaginismus or pelvic floor dysfunction when it's a vestibular problem, because I really want to get the vestibule treated. In terms of the Bartholins secrete a small amount of mucus, but it does not play a huge role in sexual activity. Most lubrication is a transudate that comes from the vaginal walls that's related to oncotic pressure. So it's blood flow to the vagina that's pushing moisture into the vagina. And then a very small amount of mucus is coming from the Bartholins. But I don't think in the data that I've seen, I don't think it contributes that significantly to people's sexual experience. Now, if it did, that's where you can start supplementing with all the lubricants that Dr. Shifren had mentioned.
Fantastic. I think we have another couple of questions we can address before ending our webinar. And there is somebody from the UK asking your opinion or experience on the use of hyaluronic acid in terms of efficacy compared to topical estrogen. Probably, Jan, you can answer this.
I think that is why I showed Dr. Mitchell's study. And again, I know it got a lot of, press, and people on both sides were kind of up in arms. The estrogen people were like, how can you say that? And I think that it was a really nice study to show that these, hyaluronic acid gel products can really be effective for women. And she will absolutely admit that, it's very hard to make an inert placebo when you need something women have to put in the vagina that looks like Replens, right? So I think it was in some ways a really reassuring study that there are a lot of non-hormonal products that at least initially will be effective. I think the principal take home from that study is it was a 3-month trial. And I think we all have women in our practice who do well, sometimes for a few years after menopause. And then we'll see them in their early 50s saying, it used to just be fine. I used lubricants or moisturizers, and now it's just not enough anymore. So I think that would be the biggest reason why I would say that study doesn't prove that, non-hormonal is effective as hormonal. But in the short-term use, we really can be looking at some of these other non-hormonal lubricants and moisturizers. And in general, in my practice, I do typically encourage those more for my patients who have a contraindication to hormones or are really anxious about hormones. We'll say, start with this first. Sometimes these are very expensive, but in general, In the United States, the vaginal estrogen products can be quite costly, or DHEA, and some of these over-the-counter things are actually less costly. So lots that might go into that decision, but it's a great question.
Yeah, I agree. We have experience with hyaluronic acid. We did a couple of studies in Italy, and it can work very well, of course. But remember, it's always preference that play a role, in my view, in the comparison between hyaluronic acid and local estrogen. Some women, they are so afraid of local estrogen, you know, that it's very difficult to do a clear comparison. And if you can take only non-hormone, probably, in my view, women that put more value on that treatment, because it's the only one they can do it, because they are afraid to take the hormones due to breast cancer or other stuff. And I don't know if somebody of you has experience on the use of topical polynucleotides. It's a question from Mexico. Maybe they have this treatment in there. I don't know, Tami, if you work by the border in California and you have experience with topical polynucleotides. I don't have any. Nobody.
And I'm about 800 miles from the border.
Yeah, it's too much. It's too much. You're right. And I would love to finish this fantastic webinar, and I thank IMS for giving us the opportunity to have this fantastic woman speaker with a sentence that was sent by a vulvar cancer survivor health advocate. I know that she's a nurse, and she want to congratulate us because it's very important to educate about the vulva. And she's also saying that we should do more about this topic, because she is a cancer survivor, and therefore she wanna involve more people in this dialogue, that the vulva is not the vagina, that we need more knowledge about this, and we should be more sensible about this topic. And probably she want to ask us, giving us a last word on if you believe that talking about the vulva into the social media, informing women, can be useful to increase awareness on this topic, vulvar health in general. And also, we talk about a lot of ovarian cancer, breast cancer. We don't speak too much about the vulva. So maybe you have a final word on that.
All right, so I mean, I think it's an excellent point. I don't know, again, what's happening in Europe and South America, but in the United States, very few menopausal women are having pelvic exams, except now every 5 years for their PAP with HPV. And so often women will say to me, well, Dr. Shifren, do I need an annual pelvic exam? And you know what, it's a hard, where are the evidence? And what I'll typically say is, clearly, if you're having any symptoms, you need an exam. But remember, you expect your annual physical exam to include an examination of the skin of your entire body. And the vulva is part of your body. And so even if your internist, doesn't do a somewhat uncomfortable, internal exam, someone needs to look down there like they look at the skin of the rest of your body. And so I think it bothers me that when we said, oh, women don't need the annual pelvic exam, I mean, you could argue it's hard to say there's an evidence-based reason that someone needs a bimanual exam every year, right, without symptoms. But there is a very easy argument that you need to look at the skin everywhere, and vulvar skin is absolutely skin. And so I think to think that a woman can have a complete exam and leave on her underwear just doesn't make a lot of sense. So I think it's an excellent point from our listener, and we'd love to hear Tami's thoughts.
I don't know, Tami, if you want to add something.
I don't have more to add, except to say this is I practice general gynecology, and I have this conversation frequently, and I think it's a generational difference. And I think again, I am more interested in treating symptoms, so that if I see GSM but someone has no symptoms from it, I'm a little less inclined to try to talk them into putting something in their vagina, because they're going to be in their vulva, because they're going to be a lot less inclined to do that. So to me, it's knowing who your provider is, so, and then counseling them about symptoms that may develop, and that if they do, they should come and see me because there could be treatment options. So that's usually how I think about it. But I agree with you, Dr. Shifren, especially when it comes to thinking about things that are not just GSM, things that could be precancerous conditions. Lichen doesn't present oftentimes. People don't notice it until it's more symptomatic. So I think that there really is a role. And so it's changing this idea of pelvic exam to maybe genital exam or skin exam that should be more included in a regular well person visit.
Yeah, it's fantastic because there is not only mucosa, there is also skin. And I think the take-home message of this fantastic webinar is speak up your vagina, speak up your vulva, speak up about yourself with your healthcare provider in order to achieve a better health. And I thank you very, very much. And I would love to have my final slide, please, because I wait you all, of course, in beautiful Melbourne for the 19th World Congress on Menopause by the IMS, 1922, October 2024. Bye-bye to everybody, and thank you for joining. Ciao. Thank you, girls.